For someone to choose their manner of dying, they may face a complex and sensitive challenge. In Australia, we refer to this as voluntary assisted dying. In Canada, it is referred to as medical assistance in dying. To hear about this experience firsthand, our guest today is Dr. Michelle Little, coming live from Vancouver, Canada. Michelle has worked for the past 21 years in surgery assistance and with the elderly population and end-of-life care. Welcome to Monday Matters. Dr. Michelle Little, you work in the space of facilitating people to end their life with dignity. What's it like for you to be part of this process?
Well, I will have to say it is my calling in life, my purpose in life now. I never saw myself in this position. When I started out as a medical student 23 years ago, I really intensely disliked old people. They were so complicated, their medication list was horrible, and they died. But as I got to know people and as I matured, I guess, I became really attached to all these wonderful people. And of course, in the older stages of life, people do tend to die. And I saw so many horrible deaths and waiting to die and wishing to die. And then I kind of stumbled across the medical assistance in dying. And I will have to say it has changed my life. I've always lived my life like tomorrow is my last day. But it brings me such joy, such gratitude that I cannot express it. It is such a wonderful, wonderful thing to be able to help people both emotionally and physically. But to be honest, it's the joy that I feel and the gratitude that I feel keeps me going, because these people are suffering so much. Like, by definition, their suffering is intolerable. Like, to qualify for voluntary assisted dying, you have to have an intolerable suffering for a disease or illness or disability that's going to take your life anyway. And I just love it so much, and I believe in it so strongly, and I've met the most wonderful people, and I have personal experiences and stories that I will tell till my dying day. I know there's a time limit today, but I could literally talk about this for hours, because it is such a life-changing experience for me to help others.
So Michelle, and you've already touched on this a little bit, what medical conditions must be met for a person to be eligible for assisted dying?
Yeah, well, it's very strict. So in Canada, it's under the Criminal Code Act. So like, it's a very serious thing. And I'm assuming it would be the same in Australia. That one, it has to be voluntary. So the patient has to voluntarily fill out forms to be considered eligible. They have to be competent to make that decision and to understand that they will pass from the medication and that there are no other forms of relief that they accept. And then you have to have a terminal illness, disability, or disease. So that is quite a range, because like, I could be diagnosed with lung cancer tomorrow and I would not qualify for assistance in dying because I'm not suffering from that condition. So, like, you could have potential suffering, but you have to have something that qualifies you at the time. So you need two physicians, or in Canada, there can be a nurse practitioner as well, that those two independent physicians, and they must be independent, have a checklist of conditions and to assess your suffering to qualify. So, of course, all your cancers qualify. You can qualify on like chronic kidney disease, chronic liver disease, emphysema. If you're on oxygen or you struggle with shortness of breath, that qualifies you. Heart failure, atrial fibrillation, chronic pain, even diabetes. So if you're an insulin-dependent diabetic, you can actually qualify, because most times you have complications of diabetes, and plus you are actually on a life-saving treatment. So one thing I love about MAID is that it prevents suicide, because a lot of people suffer with these conditions intolerably and uncontrollably, and they see suicide as the only way out. And that's not good morally, ethically, or legally. Whereas this is a very considered medical procedure that allows you to end that suffering. But the criteria is quite strict, but it's quite wide ranging. In Canada, compared to Australia, we certainly have a lot more freedom of the conditions that are eligible. So we have frailty, like basically if you're 99 and you're tired and you just don't want to live anymore, you usually have other medical conditions, but frailty would actually be one of them. So yeah, it's very, very broad reaching. The difficult part is with mental health. So Canada has just gone through a major push forward to include people with mental health disease as the sole diagnosis. That did not go through Parliament, and so they'll review it in 2 more years. But the problem is that covers dementia, schizophrenia, anxiety, depression, but also substance use, which of course in Vancouver we have a huge problem with.
Mm. Michelle, now obviously all of your patients are very different, so support for those patients must vary greatly. How do you care for your patients leading up to death?
Well, the first thing is that they have to apply. So they apply to what we call a coordination center. I can't remember what you guys call it. And that is staffed by allied health. So usually social workers or nurses who are interested in helping people in that time. So they're a huge wealth of information on, just listening to people saying, how they're feeling or their social situation. Not all families and friends are supportive of people, and that is for a variety of reasons. So we get a lot of requests that are to be kept secret until all the paperwork is done. Sometimes people don't want them to know even after death that they have pursued medical assistance in dying. So the coordination center is very supportive of that. Often people with cancer, they have their oncologists, which hats off to the oncologists. Their job is to keep people alive, but they are often very supportive when their treatments run out. Like there is just no way that you're going to win this war against cancer, or there's no treatment options left. So that's very lovely. Me personally, I think my personality is one of my greatest assets, because when I go to visit people to do these assessments, I leave them in a much better state of mind of being comfortable and comforted by the fact that they're validated, their suffering is validated, and that they can be supported, and that they have control of the situation. So they can choose a day, a time, a place, who's with them, what are they wearing, who's not there, whether they have music, whether they want to be inside or outside, but just to, I think, validate the fact that their situation's terrible. And that is having another contact besides your family doctor, which is very hard to get into, or besides your oncologist or your surgeon or, respirologist, whatever it is, to have an independent person that you can express your frustrations, your sadness, your anger, all those feelings, I think is wonderful. So even just having for a brief period of time another physician or nurse practitioner is very supportive.
Michelle, last week when we got together via Zoom to have a chat about this interview, you presided over a provision the night before. Now, this is the occasion you facilitate for a person who has decided to end their life. Can you just describe this session and some of the feelings that you have when you're going through this?
Yeah, well, I've had a few since then. That was last week.
Okay.
So basically, the way I personally work is that I give the patients my personal cell phone number. No one has ever abused that privilege. And again, it gives them a sense of connection. So in that particular case last week, it was a gentleman, he was only like 70 something. And I met him in hospital, and he had a very aggressive form of lymphoma. Like he only had days to weeks. And he knew that, and I knew that. But he wanted to go to the cancer agency to see if chemo would work, which is what a lot of people do. And the family really kind of pushed him. But then I got a phone call from the son saying, hey, Dad's really taken a turn for the worse. Can you come tonight? I have a good relationship with the pharmacist. I went to pick up the medications. I drove out to the hospital where he was. There was a whole group of family there with him. He was actually not conscious at the time, but he had signed a waiver of final consent with me, which allows me to proceed with his wishes should he not be competent on the day. I believe that's something Canada has that Australia does not yet. Anyway, when I presented to the ward, a sister from Ontario came. She was all of a sudden very aggressive, and she was just like, "I need to talk to you. I've watched Dr. So-and-so Patterson or someone on YouTube that said they basically suffocate and drown." And I said, well, that's not the case. And so I went through, as I do with everybody, the fact that they're literally going to sleep. It's exactly the same medications used as when you go to sleep for surgery. So the first one is a sedative. It's like having a couple of beers kind of thing, all in a rush. And they literally just close their eyes and start snoring. The second medication will deepen that sleep. A lot of people pass away in that time. And the third one is a muscle relaxant. So there's no changes to breathing. There's no suffocation. You cannot produce that much secretions for that. So this particular gentleman was unconscious. He had the big airvo going through his nose, like 15, 20 liters of oxygen going through. And I explained to everyone in the room, I went to draw up the medications and came back. And it was beautiful. I had warned them that when someone is breathing so hard and so fast, that when they finally let go and are at peace, sometimes it can be quite jarring, but it's such a beautiful moment when you see them physically relax and let go, and you know that they are no longer suffering. So with the sister from Ontario, as soon as I explained what the medications do and what medications they were, she was totally fine with that. She says, please help my brother. He is just in a horrible state in there. And then she asked me, is this the same medication that they use for the jail executions? And I said, oh my goodness, no, like, I don't know what they do, but it is nothing like that. Because they always fail. Like, for some reason, I don't know what they use in the US, but it is not what we use at all. So yeah, explanation and acknowledging the fact that she was anxious and upset and scared that her brother was going to be suffering even more. Once you explain all that, I've never had anyone be upset about it. And I'm coming up to about 200 provisions myself. Mm. So yeah, and so he passed. It was beautiful. As with every provision, the patient goes out with everybody saying, I love you, Dad. Thank you for a great life. Say hi to Mom when you get there, and, say hi to the dog that died 2 years ago, and it's just such a lovely thing to be hearing that as they pass. So then another lady, like yesterday, she had pancreatic cancer. She was 85. She had her 2 children and 2 friends there. So she was awake. She was alert and competent. And as she said, good night to you all. I've had a great life. I love you. Look after each other. I'm happy. And that's what she said to me when she passed. And that kind of stuff gives me goosebumps every time I talk about it, because the love and the happiness and the contentment and that the patients feel cannot be described in words, even though I try.
Well, Dr. Michelle Little, thank you very, very much for being willing to share your story, your experience, your feelings about being involved in this area. And as you term it in Canada, medical assistance in dying. It's remarkable, really, and it takes a remarkable person to be involved in this space to be able to facilitate this stage of life with such dignity. Thank you for being our guest at Monday Matters today.
My pleasure. I'm happy to talk anytime about it.